All right, so tuberculosis. I dedicated a video just to tuberculosis because I feel like it's not hard, but there's so many little things with tuberculosis that they can test you on with the meds and the presentation. So many little things that I feel like it deserves its own video, and it's important because you might get a few questions on this, and it's not hard. Like I said, you just want to be familiar with the high yield stuff so you don't miss that exam question. So let's get started on tuberculosis. Thank you as always for the comments, the new subscriptions. If I could ask one favor, if you're watching this video and you're not subscribed, it really helps the channel if you do go ahead and subscribe just to get the word out and get more videos out to people who may not know about the channel. The more subscribers I have, the more people are going to see it on YouTube. So thank you for that. It's really the only thing I'd ask if you don't mind just subscribing if you haven't yet. So let's go ahead and get started with tuberculosis. I'm sure most of us are familiar with tuberculosis, at least some of the basics. So it's an infection with an organism called Mycobacterium tuberculosis. Most common area for infection is the lungs, so pulmonary tuberculosis, but infection can present anywhere, which we'll go over in a little bit, some of the less common extrapulmonary infections. And that's the reason why the NCCPA blueprint puts TB under the pulmonary section, because pulmonary tuberculosis is the most common presentation, rather than like infectious disease or something like that, because it really is a pulmonary problem in most cases. So risk factors. This is really important because this is what's going to help you pick apart the vignette to lead you towards tuberculosis instead of some other causes that have a similar presentation, which I'll go over in a sec. So these are the first two that I feel like are the most important. These are the way I always see it presented in a vignette in questions in school and tons of exam questions that I did. You always see something mentioning either crowding or low socioeconomic status. So crowding, like a patient who was in prison, in jail, or a low socioeconomic status, particularly homeless patients. A lot of times in the vignette, they'll give you a homeless patient with weight loss, hemoptysis, etc. So those two are really big. So make sure you're aware of those. And then birth in a TB endemic country like India, Africa, China. Those are some really TB prevalent areas. And there's a whole bunch of other ones that you can look up, but if they mention anything, birth in a TB endemic area, they're not going to say that, but to know some of the big countries like that, you should be aware of that as well in a vignette. And then finally, HIV, which is a huge one. Other immunocompromised states as well, patients that are on chronic steroid use and chemotherapy, but HIV is huge. HIV, the risk of TB actually doubles within the first year of HIV seroconversion. So it's a really big risk factor. That's another big one. Again, for the vignettes, this is typically what I saw, these first two, but HIV is a big one, especially in real life, or any other immunocompromised state. So those are your risk factors. Those are the things that you need to know. Stages and outcomes. So this is really important, and sometimes this can be a little bit confusing, but I'm going to break it down into a scenario so we can run down the process. You can understand chronic latent infection, progressive primary disease, and things like that. So let's start. So you have a healthy patient, normal immune system. They're exposed to TB, wherever it is. And in this healthy patient, what happens after the TB exposure is this patient, because their immune system is working properly, they have no problems, no comorbidities, their immune system is going to properly respond. Macrophages are going to swoop in, granulomas are going to form, and essentially surround and trap the TB infection. And this little granuloma forms, and they're going to go on to develop what's known as chronic or latent infection. So let's take a look what this actually looks like. So you can see MTB is Mycobacterium tuberculosis. So that's inside of this granuloma that formed. The macrophages are in here. You have your fibroblasts surrounding it. So the tuberculosis is trapped inside of here. It's still alive. But it can't spread, it can't infect the body. So you have these immunocompetent patients that have essentially created a cage for the TB. So the infection's trapped. It's still there, but it's walled off and it can't spread or infect the body. That's the majority of patients. When they're infected with TB, about 90% are going to develop this stage of this chronic latent infection where they wall off the infection with this granuloma. Now, let's imagine the same scenario. Somebody's exposed to TB, but this time the patient that's exposed to TB is immunocompromised. Maybe they have HIV, maybe they've been on steroids for a number of months, chemotherapy, whatever it is. Their immune system is not working properly, so they can't fight off the infection, and they're going to go on to develop what's known as progressive primary tuberculosis disease or progressive primary infection. So they can develop all the things. They're going to be really sick. They can get TB pneumonia, these expansion of the infiltrates. They can go on to develop TB meningitis. Just really sick because their body couldn't do what it needed to do and wall off that infection. So that's progressive primary infection. And then let's talk about one other stage that you need to know about. So let's go back to the first patient, this chronic latent infection. They were healthy, their body did what it was supposed to, they walled off the TB infection, they're living their lives, no problems. They may not even know they have TB if they weren't tested, because they're not having any symptoms. The infection's, trapped. So what happens if one day their immune system is weakened? Maybe they develop HIV, they have, chronic steroid use all of a sudden for something, maybe some rheumatologic disorder, they develop diabetes, or they're just getting older. Maybe they're 70, 80 years old and their immune system isn't working as well. So what can happen now is the walls that the body built to trap in the TB is now breaking down, and their immune system is breaking down, and they can have what's known as reactivation or secondary infection. And that's what this looks like here. You have that walled off granuloma holding in the tuberculosis. For some reason, the immune system is not responding the way it used to. They've become immunocompromised for whatever reason, and now the infection is able to get out into the body, and that's what's known as reactivation or secondary infection. And that's why we always treat patients with latent infection. Even if they have no problems and they may go the majority of their lives without any issues, you never know if you're going to become immunocompromised, or even just the fact that, when you get older, there's a good chance that this may happen. So that's why we always treat, or most of the time treat, latent infection, even if it's causing no issues, because we don't want this to one day happen and then you lead to this bad infection. So that is reactivation or secondary infection. So those are the stages. Again, remember, chronic latent infection, those are the ones who fight off the infection, wall it off in these granulomas. Primary infection, progressive primary, that's the small portion of the population immunocompromised who can't fight off the infection. And then reactivation or secondary TB in those patients who initially fought off the infection, walled it off, but then later became immunocompromised. So those are your outcomes or your stages. So clinical manifestations, let's run down this real quick. Cough, obviously, weight loss, night sweats. You're going to have a lot of your constitutional symptoms. Hemoptysis is possible, fatigue, and then you can develop chest pain too from the enlarged bronchial lymph nodes. So like I said, a lot of constitutional symptoms and a lot of symptoms that sound very much like a patient with a malignancy: hemoptysis, weight loss, cough. So you have to be really careful when you're reading the vignette, or in real life, of course. The keys are going to be that they're going to mention something in the history to key you into TB rather than a malignancy. They may mention that they've been traveling internationally. They may mention that this patient's a non-smoker, or even that they're young, which we know is not common to see a young non-smoker, non-smoking patient with a pulmonary malignancy. Most of the time, it's an older patient that's been a smoker for many years. So you have to look for those keys in the vignette to differentiate pulmonary malignancy from TB. And they'll be there. You just have to make sure you read carefully to see. So TB most commonly affects the pulmonary system, like we went through our clinical manifestations. But like I said before, it can actually affect anywhere in the body. So there's a couple of extra pulmonary manifestations I feel are kind of high yield and they should be familiar with. There's really only a couple I feel like you should spend a little bit of time on, at least just a quick way that I found for you to remember them. So the first one is something known as Pott's disease, and I actually did get a question about this. So this has some importance because I feel like you may get a question too. So Pott's disease is TB of the vertebrae. So TB infected the vertebrae, the spine. The way that I remembered that is that these are actually pots stacked on top of one another. Actually kind of looks like a vertebrae. I mean, it does, right? So this kind of looks like a vertebral column. Pots stacked on top of each other look like a vertebral column. So anytime I see Pott's disease on like a vignette, right away I think of this, I think of the vertebrae, and then I remember TB of the spine. Hopefully that helps you too. And then the other one is known as scrofula, which is such a weird name, but it helps the mnemonic. So TB lymphadenitis in the cervical region. So you have TB infection in the cervical lymph nodes of the neck. So scrofula sounds kind of like Dracula. Scrofula here, TB lymphadenitis in the cervical region. Dracula bites you in the neck, and you wind up with this. So remember, as soon as you see scrofula, think of Dracula, bites you in the neck, and that's why you have this lymphadenitis in the cervical region. So scrofula, Dracula, remember that. That one you probably won't forget because it's such an odd name. All right, so those are your extrapulmonary manifestations. Now, what about diagnosis? So I'm going to go over the diagnosis in an acute patient first that has signs and symptoms of TB. Then we'll go over the screening with PPD, etc. after. So diagnosis in a patient coming into the ER, wherever you are, signs and symptoms of active tuberculosis. What are you going to do first? Chest X-ray. That's your best initial test. What are you going to look for in a patient with a TB in a chest x-ray. So most people, when they think of chest x-ray findings in a patient with TB, the assumption is that TB is almost always in the apices or the upper part of the lung. So that's really generally only true in reactivation or secondary TB. Primary infection is actually going to be like any other pulmonary infection, and it can generally be seen in the middle to lower lobe. So primary, you're going to see in the middle to lower lobe consolidation, and that's because it's basically just because of the fact that when these patients inhale the TB infection, the respiratory droplets just tend to deposit in these lobes. So you see primary infection in the middle or lower lobe consolidation. Now, reactivation or secondary TB is going to follow the classic pattern we went over before that lots of you are probably familiar with, and that's going to be that they favor the upper lung lobes, the lung apex, the apices. And the reason is because the apices have a higher oxygen tension, and tuberculosis is a oxygen-loving aerobe. It's an aerobic infection, meaning that it favors an oxygen-rich area, so it facilitates growth in an area with this higher oxygen tension, which is the apices. So that's why reactivation or secondary TB you're going to see more commonly in the upper lobes. Now, none of this is 100% of the time. You know, obviously you can see primary can be seen in the upper lobes, reactivation can be seen in the middle or lower lobes. This is just most common areas for them to present. So on a vignette, they're most likely going to give you the most common presentation, but in real life, remember, not everybody read the rule book, and they may not follow the rules here, and they may have an atypical presentation. So no, in the exam, you'll probably see it this way: reactivation in the apices, primary in the middle, lower lobe. Real life, it can really be anywhere. These are just the more common presentation. One other chest x-ray finding I feel like is high yield that you may get a question on is something known as miliary TB. Now, don't waste your time with this. Don't go any further than the fact that if you see a chest x-ray that sounds, or the vignette sounded suspicious for tuberculosis, and then you see a chest x-ray that has a bunch of little small nodular lesions. This is what it looks like here, almost like somebody got shot in the chest with a shotgun spray. You should be thinking of miliary TB. It's actually named after millet seeds, which is bird food. So it's those little tiny, I don't even know what it is, but it's like little tiny little pieces of bird food, these little tiny seeds, because that's what it kind of looks like these little tiny seeds spread throughout the chest, throughout the lung field there. So that's miliary TB. So don't waste your time, but just remember miliary TB. If you see a bunch of small little nodular lesions, you should be thinking miliary TB. All right, so that's your chest x-ray. What are you going to do after a chest x-ray? You're going to do something known as an acid-fast or a sputum acid-fast bacilli smear, or also known as an AFB smear. So this is going to be one of your first tests. You're almost always going to use this, and you get 3 separate sputum cultures. They're taken 8 hours apart, samples stained, and then you view it under a microscope for findings consistent with mycobacterial tuberculosis. This test is not 100% specific. Other organisms, especially non-tuberculosis mycobacteria like Mycobacterium avium, can actually appear positive on an AFB stain. So this test is not very expensive. It's fairly quick, but it's not 100% specific. So you can't really just do it by itself and say this patient has active tuberculosis. So it's a reasonably quick test. It's not really expensive, but it has its limitations. Next test is a little bit better. It's a nucleic acid amplification test, also known as your PCR testing. So the main purpose of this test is to confirm that the bacteria that you isolated in a positive AFB smear, the one we just went over, is in fact from tuberculosis and not from a non-tuberculosis type mycobacteria. So that's really the best utilization of this PCR testing. It's more sensitive than an AFB smear, but it's still less sensitive than a culture, which I'll go over next. So it's a fast test. It's actually the fastest. The results are generally back in under 8 hours. And then finally, we have your best test. Now, sputum culture is going to be your most sensitive tool for detection of TB. It's up to 98% sensitive for TB, but the problem is it's super slow, and I don't mean super slow like hours, I mean weeks. It can take up to 8 weeks to get the results back. So if you have a negative acid-fast bacilli smear, you're still going to do your culture because you want to be really sure, but don't depend on this to guide your treatment while the patient's in the ER, because again, it can take up to 2 months to get this back. You always do this because it's your most sensitive and specific, and you want to know even if it's a couple months from now, but it's not going to be something you're going to get back in the ER within a few days. Like I said, it can take up to a couple months to get this back. So if they ask you your best test, your most sensitive specific, it's going to be your culture. But remember that timeline with this. So let's really quickly review again. Sputum acid fast bacilli smear, your AFB smear. It's a good test. It's fast. It's pretty cheap, but it's your least sensitive. Your NAA, your PCR test, it's more accurate than the AFB smear. Not as sensitive as a culture. It's just good for ensuring the organism isolated is from Mycobacterium, and it's not from a non-tuberculosis mycobacteria. And it's really not used that often. Really, your acid-fast bacilli smear and your cultures are used, but the PCR testing, it's just not used as much. And then again, your culture is your best, your most sensitive and specific test, but it can take weeks to come back. Now, let's move on to screening, and we'll start with your PPD, which I'm sure most of you are pretty familiar with. Now, just go over the basics of the test. It's a tuberculin purified protein derivative. It's injected into the skin. Results are interpreted. It has to be between 48 to 72 hours. And then you measure the area of induration to decide if this patient is positive or not. Now, really important, because a lot of times, and that's the problem with the PPD test, there's a reader bias in it, because a lot of times people will measure the area of erythema, the redness around it, but you actually have to measure only the induration. That's important. So let's go over probably the only important thing I feel about this, and this is the reaction size, and this is probably where you'll get your question. So this is the one you really should know. So there's 3 different indurations that are measured depending on the patient population being tested. The way you should think about it is, the less of a risk you have for having TB, the greater size of induration you're going to get away with and still be negative. So the first one I just popped up there already is going to be your healthy patient. They have no problems, no reason why they'd be immunocompromised. Regular healthy patient, they can get away with up to 14 millimeters. So they're not positive until that size of induration is 15 millimeters or higher. So they get away with all the way up to 14 millimeters. They're not positive, healthy individuals, until 15 millimeters or higher. Next, you have some more problems. So these are going to be patients that are either hospital employees, they're residents or employees of prisons, patients with maybe diabetes, some types of malignancies, injection drug users. They're only going to get away with up to 9 millimeters. So as soon as they hit the 10 millimeter mark or higher, they are now considered positive for PPD exposure. So 10 millimeters or higher, again, that's your moderate kind of risk patients, your residents, employees of prisons, healthcare facilities, patients with diabetes, some malignancies, and injection drug users. And then we have our highest risk patients. So this is going to be 5 millimeters or higher. So these patients only get away with up to 4 millimeters, and then they're positive at that point. As soon as they hit 5 millimeters, these are patients. HIV is going to be the big one. If you're going to get a question, it'll probably be a patient with HIV. Patients with an abnormal chest X-ray, suspicious for tuberculosis, immunosuppressed patients like patients on chemo, chronic steroid use, patients that have organ transplantation, and then patients, this is another one that you might get, patients with close contact that have active TB. So you have somebody that's living in the same house as you that turns out to have active TB. They get a PPD done, or the patient living with that person gets a PPD done, and they can only have a size of induration up to 4 millimeters to be considered negative. As soon as they hit 5, because of their high risk potential, that's going to be positive PPD. So those are the ones that you need to know for PPD. Otherwise, really the only other things that to know about a PPD is sometimes they'll do a 2-part test to really make sure they're negative. Really, the 2-part test is basically, the first one's to kind of remind the immune system or wake it up. Maybe somebody had latent TB for so many years, it's almost like knocking on the door, waking it up with the first test. Then the second test, after the immune system's been like awoken, I guess you could think of it, confirms if that one's still negative, that they're indeed negative. So 2-part PPD, just a more more certain way to know that the PPD is in fact negative. A lot of healthcare workers will get a 2-part PPD. And then the other one that you should know for screening is something known as the interferon gamma release assay. So this one has some positives. So it has some positives and some negatives, of course. So it's a one-time blood test, so the patient doesn't have to come back to have it read like a PPD in 48 to 72 hours. There's no reader bias because it's just a lab test that's positive or negative, so there's nobody measuring millimeters and maybe making a mistake. It's either positive or negative. And then it's not affected by the BCG vaccine, which I didn't mention, but the BCG vaccine is a TB vaccine that's given in a lot of TB endemic countries, not here in the United States, but the BCG vaccine can actually give you a false positive on PPD, but not so on the interferon gamma release assay. So you might wonder, why don't we use this test all the time? Well, it's really expensive. So that's why we don't commonly use it, and we use the PPD, which is much cheaper. So those are the two tests for screening. Let's move on to treatment. We're almost done here. So treatment is actually not very complicated. So treatment in a patient with active TB, the treatment is going to be RIPE. So what RIPE stands for is rifampin, isoniazid, pyrazinamide, and ethambutol. So this is the treatment for active infection. Treatment is typically for about 6 months. Not all the meds have to be taken for the full 6 months. Like for instance, after 2 months, pyrazinamide and ethambutol can be stopped. But don't focus on that. They're likely not going to ask you the length of treatment for each specific drug. Just remember RIPE and that it's generally about a 6-month-long regimen. The question you're likely going to get asked when it comes to TB treatment medications likely won't be related to the regimen itself, but the ADRs of the meds, which are actually really high yield. They love to ask about adverse drug reactions about TB meds for some reason. So let's go over the high yield ADRs. They'll likely ask you some good ways to remember them. One thing to point out, remember that all of these drugs are hepatotoxic. So I'm not going to list that with each one. I'm only going to go over the more unique ADRs with each drug and the most common of the medications, but know they can all mess up the liver. So let's start with rifampin. That's your first one in RIPE. So rifampin has an R. It's the only TB med that has an R, and the R stands for red, because rifampin has this very unique adverse drug reaction that can actually turn your secretions reddish orange, your sweat, your tears. So you can see this is actually urine of somebody who's on rifampin. This is somebody else taking the medication. You can see the eyes. That's why if you wear contacts when you're on rifampin, or you shouldn't, because they're actually going to stain it reddish orange. So you can see the eyes here, the sclera, which is actually reddish orange, and you can see the urine of somebody on rifampin. So rifampin, remember, starts with an R. Think of red, reddish orange secretions. Next one is isoniazid. Instead of isoniazid, I remember isonum. Isoniazid, isonum. That's because, why am I so numb? It's because I have peripheral neuropathy. It's one of the main ADRs of isoniazid, and it can be prevented by taking this medication with pyridoxine, which is B6. So remember that. You should never take isoniazid without pyridoxine. B6, have to take them both together. You're never going to see them apart. So they may ask you a question about that too. If a patient's taking isoniazid, what else should be taken with it? Pyridoxine. Absolutely have to remember that. Otherwise, there's a much higher risk of peripheral neuropathy. So isoniazid, isonum, because I have peripheral neuropathy. Next one is pyrazinamide. So pyrazinamide, what I want you to think is, instead of pyrazinamide, I want you to think of the pyramids. Now we have to be very creative here, but let's take a look here. So pyrazinamide, think of pyramids. So I want you to think of the pyramids being built stone by stone in the middle of a hot, you can see like the stones being pulled up in the middle of this hot desert. People building them are clearly getting sunburn. You can see they're in the middle of the hot desert. So when you think of pyrazinamide, think of the pyramids. They were built from stone. So that makes me think of hyperuricemia. You can see a uric acid stone that comes from increased uric acid in the body, as well as of course, the gout that you can get from hyperuricemia, the crystallized stones that you get in the joints. So remember, they were building the pyramids from stones. Actually, limestone is what all the pyramids are built from. So as soon as you think of the stones that the pyramids were built from, you think of uric acid stones depositing in the urinary tract, as well as the joints and gout. Next, sunburn. Remember, the pyramids were built in the middle of the hot desert. All of these people in the hot desert, you think that none of them have a sunburn? I'm sure they all got sunburn. And that's important because another side effect of pyrazinamide is a photosensitive rash. So pyrazinamide, you can see the photosensitive rash here from pyrazinamide. So as soon as you think of pyrazinamide, think of pyramids being built by stone, hyperuricemia, and then you think of sunburn because they're in the hot desert, and that is your photosensitive rash. So those are the two side effects you should know. Pyrazinamide is going to be your hyperuricemia and your photosensitive rash. The last medication is ethambutol. This one's a little bit easier. Ethambutol is the only TB med that starts with an E, so think of eye, and optic neuritis. So patients with taking ethambutol get optic neuritis, leading to, of course, the changes we know with that, like visual changes, problems with color perception. One last thing, be aware that if a patient has a contraindication of ethambutol, an allergy, whatever it is, streptomycin can be used in its place, in which case the mnemonic would be RIPS instead of RIPE. So just remember that it's not commonly used, but if for some reason the patient couldn't take ethambutol, streptomycin is a possibility. And I think they actually did that to me on my OSCE, and they said, you're treating active TB, patients allergic to ethambutol, what are you going to use? And luckily I remembered that, but streptomycin instead of ethambutol if that's asked. So that's your treatment for active TB. Latent TB is very easy. It's basically isoniazid plus or minus a rifamycin class medication. So that's either rifampin or rifapentin. So none of the treatments available for latent TB have been shown to be superior to another. So whether you choose, you can do just isoniazid by itself, you can do rifampin by itself, you can do a combination of isoniazid and rifampin or isoniazid and rifamycin. It just comes down to the likelihood for patient adherence, provider preference, avoidance of certain ADR. So they can't ask you to pick one over the other, or they shouldn't, because there is absolutely no superiority of one regimen over the other, and that's straight from Up to Date. So if they ask you that, it's a bad question. So they probably will not. So just know treatment. If you see latent TB, you're going to see something with either isoniazid or a rifamycin class medication, so rifampin or rifapentin. So any one of these combinations, they can't ask you multiple because there's not one that's better than the other. So that's pretty straightforward. So that's the treatment for TB. Let's just do 5 quick questions and then we are done and we'll wrap it up. So question number 1, tuberculosis of the vertebrae is known as. Tuberculosis of the vertebrae, that's going to be Pott's disease. Remember, your pots stacked on top of each other, they look like vertebrae. Question 2, patients with secondary or reactivation TB will most commonly have localization of cavitary lesions in which region of the lungs? So secondary TB is most commonly going to present in the apices or the upper lobes. Remember that higher oxygen tension. Question 3, which TB medication can cause reddish-orange secretions like reddish-orange tears, urine, sweat? That's going to be rifampin. Remember, rifampin R, red rifampin. So question 4, patient who is currently living with his brother who has active tuberculosis would have a positive PPD at what size of induration? So he's living with his brother who has active TB. What size is that PPD going to need to be positive? Or the minimum size, that's going to be 5 millimeters or greater. And then question 5, chest x-ray with diffuse small nodular lesions likely has which type of TB? So diffuse small nodular lesions kind of look like millet seeds. That's going to be your miliary tuberculosis. All right, so that is TB. Hopefully that was helpful. I want to thank you again, as always, for all of the comments, the new subscriptions, everything. You guys are great, and I really do appreciate it, and I'm so happy that this is helping you. So please let me know in the comments if it's helping you. Please, send me a message, a like, and please subscribe if you have not yet. And good luck on your PANCE, your PANRE, your EORs, and good luck in PA school.